Our next speaker is Sammy Elmariah, who is an assistant professor at Harvard Medical School and one of our interventional cardiologists who actually does the valve procedures he'll be talking about, but is looking for better ways using small molecule profiling to identify patients and predict their outcomes. Sammy, thanks so much.
Thank you very much for that kind introduction. It's a pleasure to be here today. So I will be speaking to you about valvular heart disease today. Valvular heart disease is a tremendous public health problem affecting our elderly population, and the impact continues to grow as our patient population continues to age. In patients over the age of 75, over 12% of patients have a significant valve lesion, and in 2013 alone, over 50,000 deaths were attributable to valvular heart disease. Now, for the purposes of today's talk, I would like to focus our attention specifically on the aortic valve. Aortic valve stenosis is characterized by the progressive indolent narrowing of the valve orifice to the point that symptoms develop once left ventricular compensatory mechanisms begin to fail. Once this happens, survival diminishes to 50% at 1 year unless the valve can be replaced. Now, historically, despite this amazing fact and this dismal prognosis, only half of patients were offered surgical valve replacement because their predicted risk of morbidity and mortality was thought to be too high. Today, we can offer these patients TAVR, or transcatheter aortic valve replacement. Now, even in the sickest of patients, we can replace the aortic valve without median sternotomy, cardiopulmonary bypass, and often even without general anesthesia. And many of these patients are sent home within 1 to 2 days. And as you see by these figures, our armamentarium to treat other valve pathologies is rapidly expanding to include the mitral, tricuspid, and pulmonic positions as well. These collectively are perhaps the biggest thing to hit cardiology since the cardiac stent. But despite this tremendous advance, numerous challenges exist. So for example, I have limited tools to determine which of my patients will thrive, as this patient in the upper panel did, and he went on a successful moose hunt soon after his TAVR, and which patients will fail to thrive and will return to my office frail, wrapped in blankets, and in a wheelchair. My work seeks to utilize small molecule profiling techniques in order to answer these very questions. So small molecules, specifically metabolites and proteins, serve as the end product of many of the regulatory processes that occur within a cell, a tissue, or an organism. And they can consequently provide insight into the body's response to a disease state, to a pharmacologic therapy, or to invasive intervention. The ultimate objective of this work is to gain mechanistic insights into valve pathology, to hopefully uncover novel predictive biomarkers as well as pharmacologic targets, and to allow us to personalize the delivery of these interventions. Now, what exactly do I mean by that last statement? So one of the most obvious applications of this technology is the prediction of clinical outcomes and complications after TAVR. So we and others have shown that acute kidney injury is associated with dismal survival after TAVR, as you see here. But the question then arises is, can we predict it so that we may find ways of preventing it? And in fact, we can. So we have identified several metabolites that predict acute kidney injury to a greater degree than does serum creatinine. 5-adenosyl-homocysteine, which is a potent inhibitor of DNA methylation, was the strongest predictor of acute kidney injury. As you see here, patients within the lowest tertile have a 0% risk of developing acute kidney injury, whereas the risk in those within the highest tertile is almost 50%. Moving our attention then to survival, we find that by assaying a collection of renal metabolites that are orthogonal to filtration, as well as metabolites involved in nitric oxide synthesis and also atherogenesis, that we can also predict survival, 2-year survival after TAVR, as you see by these time to event curves. Now, importantly, these metabolic data are actually supplemental to currently accepted clinical risk prediction scores. So if I were to stratify patients based on the Society for Thoracic Surgery risk score into 3 risk categories, you see that additional prognostic information is gleaned within the lowest risk patients and in the highest risk patients by adding this metabolic data. This is enough to reclassify patients into different categories and which certainly impact our treatment choices. So the next step is to validate these findings. I'm working and collaborating with many investigators across the US and internationally, and of course would love to partner with industry in order to do so on a larger scale. One obvious method to do this is to incorporate blood collection into ongoing randomized clinical trials. And then, of course, beyond that, to help devise ways in which we can modify this risk. So in addition to hopefully reducing complications, I would also use to apply this technology by personalizing the timing of valve replacement therapy. So aortic stenosis, current guidelines suggest that we should defer valve replacement until a patient either develops symptoms or until the left ventricle begins to fail. We know that by the time this happens, myocardial fibrosis is often extensive. Myocardial fibrosis is an irreversible process that is associated with a 6-fold increase in mortality despite replacing the valve. Why then should we wait for this irreversible and damaging process to occur before we intervene? Wouldn't it make more sense for us to identify patients who are at high risk in order to intervene earlier so they may reap the full benefits of these interventions? My underlying hypothesis is that the blood carries metabolic signatures of what is occurring in the heart. And by essentially biopsying the blood through these assay techniques, we can learn more about what's happening in the heart and use this information to guide cardiovascular interventions. And our data is starting to show that this is in fact a reality. So we have found that in patients with left ventricular dysfunction, 40% of patients do not reap the benefit or the improvement in systolic function that's expected after TAVR, and that these patients have a 2-fold increased risk of mortality after you replace their valve. These hearts are essentially just too sick. We have also found that TAVR acutely impacts the myocardial energetics. Here you see that the long-chain acylcarnitines, which are indicative of fatty acid oxidation as well as mitochondrial metabolism, acutely improves within 24 hours after alleviation of the aortic stenosis. These very biomarkers correlate significantly with left ventricular ejection fraction and also with left ventricular mass. But what is the most exciting is that we can actually predict which patients will experience an improvement in left ventricular systolic function. By assaying tryptophan metabolites, you see that patients within the lowest tertile of this metabolic class have a 50% likelihood of experiencing an improvement in LV function compared to only 13% within the highest tertile. Now, the next step is to test the clinical applicability of these findings, and I would love to partner with industry in order to do so. One way of doing this is to execute a randomized clinical trial in which we would randomize patients with severe aortic stenosis to a metabolite-driven early intervention strategy and compare this to the currently accepted symptom-driven strategy, with the hopes that the addition of metabolic data will improve survival, symptom status, quality of life, and functional recovery. So I hope I've convinced you that the small molecule profiling holds tremendous value in helping us to personalize the delivery of these costly and invasive procedures. TAVR has disrupted the treatment of patients with valvular heart disease, and I believe that it's time for us to move beyond this and to actually disrupt the paradigms that actually drive our decision making. Thank you very much for your attention.